So, today we'll be learning about the urinary, from the urinary system, about the ureter and urinary bladder. And why I'm showing you these water drops in the background, because it's all about water and water business. Well, this water is urine, we don't like it, but this is something is really important. Let me share with you. I remember I was in a transplant team, and one of our first case in our unit, the patient, when we plug in the new kidney in the patient's body, and we all wait, we give some medicine to the patient who have received the kidney, and the first drop of the urine when it is being made, oh, that's an event. That there lies the success of your surgery, and people celebrate, you cannot imagine. It's a big party time. Anyway, with this note, I like to start. So today we'll be talking first about the ureter. So what is ureter? Ureter is a fibromuscular tube. It's around 10 inches long. And 10 inches, if I convert it into, it's around 25 centimeter. And it extends from the hilum of the kidney, and it is going towards the urinary bladder. It is a long journey. It runs in the posterior abdominal wall. It is also a retroperitoneal structure. Partly it traverses within the abdominal cavity, then it has its journey in the pelvic cavity, and then it has its journey when it enters obliquely in the wall, through the walls of urinary bladder, and it enters into the cavity of the urinary bladder. So the journey taken by this ureter, for our convenience, for our easiness, we divide it into that. We say, oh, ureter has an abdominal part, ureter has a pelvic part, and ureter has an intravesical or intramural part. So for our simplicity, for better understanding, we say that way, that the ureter, it's a tube, it's a drainage tube which connects, which carries all whatsoever kidney. We all know the kidney is a filtration unit, and all the filtration which has been achieved by the kidney, that filtrate part has been carried by this tube, which is a fibromuscular tube. It has the same peristalsis activities. It's not like a simple drain. So it has the peristalsis, and when we'll be talking on the x-rays, there we'll be looking into different things. So because of this peristalsis, this urine is being propelled. It travels through its length. Part of it, it lies in the abdomen. We call it abdominal part of the ureter. Part of it, it lies in the pelvic cavity. We call it pelvic ureter. And the part when it is going obliquely through the wall of the urinary bladder, this is there. Everything has its importance. Everything has its significance, and we'll try to go over step by step. So I'm sure everybody is fine with that. So let's proceed. So now, on its way, I have made what? There is a kidney with a suprarenal gland sitting on top of that. You're looking at an aorta bifurcating at the fourth lumbar vertebrae level, and you can see an inferior vena cava which is making at fifth lumbar vertebrae level. And there you're looking at the common ilex, and there is the urinary bladder. Now the caption is what? The site of ureteric constrictions. I'm sure you remember some time back when you were learning esophagus, you were explained, you were taught that esophagus, on its pathway, it is narrow at certain points. That is not a disease. That is not a problem. This is something natural. So we have to, same formula applies for ureter as well, because it's a long fibromuscular tube, and on its pathway, it follows certain places where it becomes narrow. And this narrowing is due to certain structure, either it is passing by, either it is compressed by, or it is overlying by something. So now this is one of the, if you are ever asked about a ureter, remember, and if somebody is writing an exam on a ureter, and if he is not asking the constrictions, means this exam is without a ureter. So this is a must know slide, and I expect all of you should be excellent with this concept. So now let's first make a ureter. So now you can see yourself, the ureter started its journey from the pelvis of the kidney. And we all know who contributes from the cortex. We have the medulla. Medulla has the pyramids. Pyramids concentrate at the papillae. Papillae opens into the minor calyx. Minor calyx, so many minor calyx join to form major calyx. Three major calyx, upper, middle, and lower, they join to form a pelvis. and this pelvis becomes ureter. You can see the pelvis is coming out of the hilum of the kidney. Now it becomes ureter, and then it has journey. It has a part within the abdominal cavity. We just said this is the abdominal ureter. Now it entered into the pelvic cavity from here till here. This is the pelvic ureter, and you can see that there is something shown here, that is the intramural or intravesical part of the ureter. I hope we are fine with this concept. Now we are hunting at what are the places where this ureter is narrowed. Structurally it is narrowed. So this is the ureter, we all know. So it has three normal sites of narrowing. I'm not talking about pathology. I'm talking about structural, functional, like when it is made, it is being narrowed. It is made with these narrowings. These are not man-made. These are not because of some disease process. Those are other things. We are not talking disease here. We are talking about normal structures. So now this is the first place with this red circle. So what do you think? What I'm trying to show you at the moment, this red circle. Can you comment the name for that? Uretero-pelvic junction. Excellent. So the place where my pelvis become a ureter. So UPJ or PUJ, both of the answers are acceptable. You guys are mashallah good. I'm really impressed the way you are responding. So the first narrowing site is where we have this uretero-pelvic junction, where the renal pelvis continues as the ureter, or it becomes the ureter. So this is one site. Are we good with that? I hope there should not be any ambiguity. Okay, on the track. Now you can see when this ureter is crossing these common iliacs. So we can use the term like Sarah is writing, pelvic brim, or we can also say when it crosses the common iliacs. The common iliac vessels, where it crosses the common iliacs, this is a place, this is the same place. Either I call it pelvic brim, or I call it when it crosses the common iliac vessel. You can see this thing. And pelvic brim you have not seen yet. I will be showing to you shortly. That is just because of the bone, that area is given the name, and that's an entrance point. So now this is point number 2, pelvic brim, as it passes over the bifurcation of the common iliac vessel. So this should be your answer number 2. And there is no doubt about these words. So you are expected to use these guys. Writing exact words for specific answers yields you what? Full marks. And if you play around with little bit and you are, oh, I wrote it right, but why I'm not? Ureteroiliac, Kautar, we are not using this word. We are more confined to say pelvic brim, or when it crosses. So the most appropriate word is the pelvic brim. Try to use that. Okay, going down. Now the third place, when it enters, excellent, Sarah, you are writing right. So uretero-vesical junction, the place where the bladder is entering, where it is meeting the vesica. Vesica word is used for urinary bladder. So where ureter enters the urinary bladder, and that is VUJ, vesico-ureteric junction, or uretero-vesical junction, as it enters the bladder, the wall of the bladder. And I'm sure you must have seen in the video which has been uploaded, and I'm sure you have seen it on YouTube or wheresoever you have access. I'm sure everybody knows where it is. So now, guys, everything which comes in the red box, I always told you, never ignore it. Red box, blue box, and green box. And I'm sure by this part of the year, everyone knows where are these green boxes. Green boxes are found in Gray's Anatomy. Blue boxes are found in Moore Anatomy. And red boxes are found in my presentations. So let me read it for you because it's so important. These sites of normal narrowing are important clinically. Why they are important? Because if a stone is formed, what causes the constriction? These are the natural constrictions, Muhammad. They are nobody is responsible for that. These are the natural narrow sites in these places. Because if you look at that, let me answer you. The pelvis is becoming ureter. The ureter is going over a surface, so it is a dent because of its natural location. And this is entering into another organ, so there is some natural resistance. And it also prevents something. Otherwise, if someone's bladder is full, the urine is liable to go back right up to the kidney and causes disaster. Like people hold their urine. Oh, when I'll go home, then I'll visit hammam. No. If you have a urge to pass urine, you should pass urine. Because, and if there was not this oblique entry, if it was not this narrow side, so then there were so many, a mechanism is involved here, and mechanism is needed so that urine should not go upwards. It is prevented. It acts like, there is no valve, but it acts like a valve. This organization, the oblique entry of the ureter into the urinary bladder, is really important. And those people who don't have this, they suffer in a big way. This is called a reflux disease, and it affects their health in a big way, and they are always having infections. And infections in the kidney are never a good thing. So now what I'm writing, clinically, because kidney stones tend to get impact. So these are the narrow places. So if a stone which is formed in the kidney and now it is falling because of the pressure of the urine, it is falling down, it can stuck here, it can stuck here, it can stuck here. So these are the normal common sites and give rise to a very specific type of pain, which we call it as a renal colic. Renal colic is one of the very disastrous type of pain, and the renal colic is usually referred from loin to groin. So, I'm sure you will be knowing, or if you're not knowing, you should be knowing these terms. Loin is at your back. From loin coming forward, in the next slide, I'll be showing you where is the loin and where is the groin. So it's coming towards your medial side of the thigh, close to your labia or close to your testes. So this is how. So the reflux happens when bladder is emptied. No, my dear Sarah. Reflux happens when bladder is over distended. Your bladder is full, and if this mechanism is not working, the catch is, if this mechanism is not working, then urine is liable to go up, get into the ureter and get into the kidney, and this stasis. Look, if I leave something which has toxic material, nitrogenous material, for a longer period of time, what will happen? It will become rotten. There will be fermentation, bacteria will grow, and it will be a disaster. It will be a source of infection all the time, day and night. That's why even our religion says, when you have an urge to pass urine, don't hold, just go and evacuate, empty your bladder. So now, I hope you are good. Why I'm emphasizing so much on this slide? Because I want everybody should be very good with these 1, 2, and 3. If somebody ever asks you, and for sure you'll be asked, what are the constriction sites in the pathway of the ureter? These are the common anatomical sites. There are others. If you want me, I can make them 7 to 8 and 9 and 10, but that's not normal anatomical sites. The normal anatomical sites are only 3, where simple to remember, where it begins, where it ends, and in between when it is crossing over the pelvic bones. So ureter from the kidney to the bladder. Let me see it, what you're writing. Ureter from the kidney to the bladder, isn't it vertical? Yes, it is vertical, Sana. But the point is, you don't expect the urine flows because of the gravity. We have the peristalsis. There is a peristaltic movement which is always there. Okay, so now let's move to the next slide. So next slide, now I'll be showing you, guys, this slide, I need your full attention here. What I'm trying to show you, when people have a stone which is traveling, which was made in the kidney, and when this stone is formed, it will travel. When people have pain, the renal colic, when it occurs, when this stone moves, if the stone sits for years, the patient will not experience any pain. Pain only occur when this stone moves, and when the stone moves, they are not very smooth. If you want to look in more detail, go to your lab resource material, click the kidney, and in the kidney, when you finish the normal learning, the first video which will be appearing is the first section is the urolithiasis, where the stones, how the stones are formed and how we clear them. So just watch those videos and see the pictures of this different stone. So anyway, so this stone has been formed and it has been traveling. And when it passes, when it reaches to these different sites, what patient experience. And also I'll be showing you here what is loin to groin. So now this referred pain, just stay connected. So pain of ureteric colic. So when the stone is entered into the ureter, and now when it causes pain. Why we have a pain when we have a stone in the ureter? Any idea? Would you like to share with me why someone experience a pain when there is a stone in the kidney? Can you write? Why patient experience a pain when there is a stone in the kidney, in the ureter? expansion, muscles from the peristalsis, friction, kidney becomes enlarged. Guys, excellent, you guys are writing very nice. Basically what happened, if this stone obstruct here, first thing is obstruction. It obstructs here, so channel is closed. This place will enlarge, so spasm, stretch, visceral. It is a referred pain, is a visceral origin pain, is radiating. Connect to the dots. Pain comes when there is an obstruction. Obstruction leads to what? Stretch. Stretch initiate pain. Visceral, autonomic come in play. And then we experience pain where? Not in the ureter. We experience pain at the back. Patient will talk, oh doctor, my pain is at my back. And you are saying the ureter is not at that place, what he is talking. Or he is saying, I see the pain is radiating towards my testes. Pain is radiating towards my labia. So now who explains? So this is the referred pain. Excellent. So now let's stay focused. Look at this stone and see what happens. Now look at it. Focus on this stone and see how it moves. And I'll be putting in the box. So which segment of the spinal cord the pain will be perceived. So look at it. This is kidney and the renal pelvis. Stone is located at this place. If the stone is here, the pain will be felt at T10 to L1 level. The pain will be felt if stone is here. The pain will be felt in these segments of the spinal cord. Guys, these numbers, you may find some difference when you open up different books, but it is ranging from 1 to 2. It could be 9, it could be 11. So that's not a rocket science. So if the stone lies in this location, the pain will be experienced in this segment, which is appearing in this red box. Now, going down. What happens? Look at it. This stone is going down. It has stuck to the second constriction site. Previously, it was at the first constriction site. Now it has reached to the second constriction site. We all know it is at pelvic brim. When the stone is stuck at pelvic brim, causes flow, interruption in the flow. That will lead to stretch. That will lead to stasis. That will lead to inflammation. That will lead to pain. Now, when the stone is stuck at this place, the patient will experience pain. In the abdominal ureter, he or she will experience pain from T11 to L2. So these are the segments. And when, look at this stone, now it is going to the junctional part, pelvic-ureteric junctional part, and at the opening within the urinary bladder. So now, why inflammation, Hashim? When the stone stuck here, urine is not going down. So urine stays in this place. So over a period of time, there will be fermentation, bacteria will grow. Look, if I leave some water, some healthy water, some nice water in a container and just let it stay for few days, what will happen? Will you like to drink that water? It will be, there are fair enough chances, there might be some bacterial, and see after rain, the water turns green. Doesn't the stone compress the common iliacs? Stone will not compress because the common iliacs are having very strong pressure. Will the inflammation of one is in the pelvic brim affect iliac? No, that will not affecting the iliac vessels. They will be affecting the urinary system because the pressure is very different. And these iliacs, you cannot believe how much immense pressure they carry. So now the stone is stuck at the opening part. So now where the pain will be felt? So the pain will be felt in the pelvic ureter if the stone is in the pelvic ureter and it's stuck. So the pain will be felt at L1 and L2. So guys, these boxes you need to be connected. And they are connected to these sites. So what we were talking at PUJ, T10 to L1. In the abdominal ureter, if it's stuck, T11 to L2. And if it is at the uretrovesical junction, L1 and L2. If the stone is at the ureter, wouldn't it be block the urine flow? Yes, it will block the urine flow, Yazid. If it is big enough, it will block. And a result will come what? This whole thing, I have so many slides on that, it will be coming up. Relax. This stone business is a big deal. Remind me. So now, are we good? So radiation of the ureteric colic pain. Now, I said a word in the beginning. What is loin to groin? The levels are overlapped. How do we differentiate between where it's stuck? It gives you a rough idea. And when we'll ask this question, we'll give you some supporting X-ray. will give you some other things. So things will be supplementing, or will be providing you a location, or we will not be asking you, patient is having pain in T11 and L2, where the, there, our questions. We are not like giving you something random or blinded. So now focus on what is loin to groin pattern. Just watch in these two pictures. So see what happens. This is back, loin, and then it's coming to the groin. From the loin to the groin, from the back coming to the front. Do you understand this? This is a very important concept. So the pain radiates, a classic pain when a stone moves in the ureter anywhere. The patient will complain, the pain, it begins, you ask the pain where it begins. It begins in my back. And now it's radiating towards my testicle, if it is a male. And if it is a female, towards my labia, towards my medial thigh. So this is a classic of, like see for appendix, you learn what? A pain starts paraumbilical and radiates to the right iliac fossa. So that was a classic pain of what? A pain of acute appendicitis. A pain which initiates after having a heavy fatty meal on the right side, gallbladder, gallstone. Pain which has been seen radiating towards the back, in between the scapulae on the back. It was classic of acute pancreatitis, alcohol consumption. The pain which is on the left side of my chest, fifth close to my nipple, oh, it is something radiating to my arm, oh, MI. So we are having certain classics. So this is one of them. The pain when the stone is in the ureter, coming from the back, from the loin to the groin. That is classic. But if the stone is in the kidney, pain will stay on the back. It usually don't radiate down. And patient will feel like, doctor, I feel like as if stone is about to come, because this sensation will be there. So the pain, now you have to differentiate. If pain stays in the back, pain in the loin, yes, stone in the kidney. Pain from loin to groin means stone is anywhere in the ureter. Stone is anywhere in the ureter. Now we have to do some investigation to identify. So do we say that there is a pain from loin to groin, taking constriction, its exact location? We cannot reach to the exact location unless we have some radiological investigation with us. But remember, pain which is localized to the back in the loin, think of a stone staying in the kidney. And if patient talks the pain radiating from the loin to the groin, oh, you start thinking of a ureteric pain. Now, how you will establish where is this stone is? You have to have certain type of imaging. First, you'll go for an ultrasound. Then you need to have some X-ray, special X-ray KUB. I'll be uploading a video how to understand an X-ray KUB. Then we have certain specific investigation. I have all those things. This pain is so sharp. You keep rolling on the floor, on the bed, and you have a suicidal tendencies. Doctor, can we stone be dissolved in the urine? Gentlemen, it's a blessing. It's a blessing. Anything less than 6 mm, everything is possible. You drink, you do this and that, you drink this holy water, you drink this magic medicine, it will dissolve. If it grows bigger than 6 mm, now it is the time where it's stuck. So 80% of the stone, they pass out of the urethra. Patients see them passing in their urine. But the criteria is less than 6 mm. When it grows big, it got stuck. Then it depends on. So I highly suggest you go and watch the video which has been made on, which is available there on your lab resource place regarding these stones, how they are formed, where they are formed, and what they are treatable. So the stones are in the kidney, cause pain only in the back. Yeah, mostly the pain stays in the back. And if you're having pain from radiating from the loin to groin, you think of a stone in the ureter. But we cannot believe only on this. We have to have some investigation. So cloudy urine from the stone passing, cloudy urine you can get for so many conditions. So this is a very, urine report can be presenting to you an infected urine. That's possible in so many conditions. But we have to be specific because we believe in evidence-based medicine. So we need to provide an evidence with the help of some radiology, some X-ray, some ultrasound, some MRs. So many things are needed, some CT scan. Genitofemoral doesn't play here. We'll talk, guys. Let me go over. Otherwise, I know this is so interesting topic and this 1 hour is not enough. I know, but I have to finish the thing. We will talk about it in more detail. Will the ureter bladder folder will be, yeah, they will be available shortly. And you know my channel, you can go there and those videos are there as well. But these will be opening the next week. These ureter bladder videos, they will be opening because they are the objectives of the next week. Not in like the first lab, they will be objective of the second lab. Don't worry for that. Everything is provided. We are not hiding anything. Okay, guys. So now we are good with that. I'm sure we are fine. So now we have talked about loin to groin. I'm sure you have understood something out of everything, and with the time you'll learn everything. Don't worry, relax. And I'm there to help you. I'm open. If you need, write on the discussion forum. If you are shy, write me an email. I love to answer you. So dermatomes to which the pain of ureterocolic is most commonly referred. These are also spinal cord segment giving rise to the visceral afferent. So you can read these lines, and that has been. So look at this box is matching with these boxes. So can these stones pass through the urine? Yes, they pass through the urine. But the point is, Osama, they have to be small enough. 6 mm is the cutoff point. Anything grows bigger than that, or there is an alteration in the shape of the stone, then it's difficult, they got stuck. So only 20% of the stone, they are coming to the urologist for their removal. 80% pass on their own. That's not a problem. Okay, let's go further. So now, ureter is a highly vascular organ. You can see that it has different arteries which are supplying throughout the length of the ureter. Look at it, the upper ureter, close to the pelvis. It has a branch from the renal artery, both on the right and left side. Then you can see that there is a gonadal artery which is crossing in front of the ureter. So it gives a contribution to the middle part of the abdominal ureter. Then we have a direct branch from the aorta that is also supplying the ureter. Then from the common iliacs, you can see there's a branch which is supplying to the ureter. From the internal iliac, you can see there's a branch coming from that. And there are so many numerous branches. All of them, they are contributing to supply ureter. So you can see that how rich is the blood supply. So a stone, when it moves, it not only causes pain, patient might present with some change in color of the urine, the pinkish color, the reddish color, that is called hematuria. Hematuria means passage of blood in the urine. You learn the terms hemoptysis, hematemesis. Those were with the upper tract and GI. Now with the renal tract, with the urinary system, we call it hematuria. This hematuria means heme in the urine. So, and you can see that, and the urine becomes cloudy, not cloudy, the pink or the red only when the stone moves, and with this movement, its sharp edges, they cut with the mucosal walls, and you can see the high vascularity in the kidney as well as in the ureter. So these are enough to cause some leakage of the blood, and this blood will be seen in the urine which has been passed. So these people, they present with a renal colic, present with a pain, classic. If the stone in the ureter, pain from loin to groin, one. Second, difficulty, burning, like patient don't want to void because every time he passes urine, there's a burning as if a fire is passing with his urine. So that's another thing. That is because of the inflammation, fever, and then the color of the urine. So these are the hallmarks, these are the parameters which directs you, oh, there is something wrong with the urinary system, and these points should not be ignored. Okay, so now this is the label picture. Don't worry, I have provided you everything. So you can see that in female there we have vaginal artery, we have contribution from the vesicle, uterine. So everybody is supplying to the ureter. So ureter is not alone on its journey. So many one are there to take care of it. And guys, you are expected to be good with these labels. We love to ask this. Okay, now I'll be showing you what on the way ureter is associated. There are so many vessels, they are closely related to the ureter. So we'll be looking at them. They are clinically significant, but they are not the sites of, is the stone always sharp enough to cause hematuria? Usually the hematuria, if it is because of a stone, is because of the sharpness. I will show you. These are crystals. Have you seen crystals? They are very sharp edges. Some stones are rounded. So it's a different scenario. So now let's focus on how different vessels on its way from the renal pelvis to the urinary bladder is related to the different areas. And these areas are having some clinical significance. So now the three important vascular relationship of the ureter on its way from the kidney to the bladder. So now let me focus one by one. So now look at it. The ureter is crossed by the gonadal vessels. The hematuria happens due to the rupture of the arteries. My dear, it's not the rupture of the arteries, it's just the laceration of the capillaries. If artery ruptures, it's a disaster. Then they are outside. So, first site, ureter is crossed by the gonadal vessels. A very important site. Second site, ureter, you can see it's crossing over. Here, ureter was crossed by the gonadal vessel. Now, and in the lower position, now ureter is crossing above the common iliacs. So that is the second point. And the third point, look at it. The ureter is crossed by the uterine artery in case of females. Inferior passes posterior and inferior to the uterine artery only in case of females. So these are three important locations where ureter is in direct contact with these blood vessels. So one has to be careful. These are the things which are needed for the people who are practicing surgical procedures while they are handling stones or other things. But these are really clinically significant landmarks, and don't ignore these circles 1, 2, and 3, and they are indicated by these things. So these are the must know type of information, and you are expected to be good. Okay, let's proceed. So important not to tie the ureter when ligating the uterine artery. I'll be talking about it in the clinical anatomy lecture. Relax. So now, left renal vein, we talk about it. It is also another site. Left renal vein is crossed by. So this is, we have talked about this, that what happens to the left renal vein and the suprarenal. So this description is good to know because it's in the red words. Don't ignore anything which comes red. Okay, now I'm showing you the X-ray image, a special X-ray. We call it IVU, intravenous urogram. Old days, people call it IVP. Look at it. We give a contrast material, we inject through the veins, and then we, on a certain specific time, after 5 minutes, after 10 minutes, after 15 minutes, we take X-rays. And look at this contrast. After it reached to the kidney, now it is been excreting. And now what is visible to you? You can see the pelvic calyceal system. You can see the minor calyces. Other system will not be revealed. You can see these upper, middle, and lower calyx, major calyx, the renal pelvis, and you can see the upper ureter. You can see the whole length. It's going all the way down and obliquely, and then it entering into the urinary bladder on both the sides. So this is a normal IVU, is a contrast study where you can see, and there's no stone. If there was a stone, we could have seen the dyes, the contrast material is not going further. Does it only pass on the right side? It's on both the sides. So you can see that this is a contrast study which is helpful when somebody present to you with a pain from loin to groin, with all other symptoms, some color, some pinkish coloration of his urine, hematuria, and all that. Then you advise an X-ray chest after having an ultrasound, and there this IVU is really helpful in localizing the site of the stone. And once you know where the stone is located, then it will be very easy for removing these stones. Guys, after this lab finishes, the next lab resource material where we'll be talking about ureter and bladder, there you'll be finding some small videos how we really remove these stones. So they will be interesting and helpful for your understanding. Look at it. So this image has been magnified, and there is these are the special techniques. You need not to know. That's why I didn't mention the name of this technique, but you can see the whole of the system. You can see the minor calyces. They are making the upper major calyx, middle and the lower major calyx, the renal pelvis on both the sides, and look at the ureters. Even if you think there is a stone, no, there is not a stone because there is a peristalsis. So it's not a same tube, because with each propulsive movement, you can see dilated segment. Here you can also see some part is missing, some part is there, some part is missing, some part is there. See, it is missing all the way down here. It doesn't mean that there's a stone here. No, because there is a peristalsis. So it is a different times. And there you can see this is a reconstructed image, and it is showing you more details. I hope things are more fine. And look at it, urinary bladder is filled with the contrast. Why in this one, the kidney is lower, because you can understand which one is lower and which one is upper. And there are so many different locations. Okay guys, so now let me show you. This is a very interesting X-ray. Now there I'm showing you something wrong. Look at it. On the left side, always you are indicated, there is an L, there is an R. If L is there or R is there, to help you to understand. This is the left side. Left kidney, look, everything is minor calyces, major calyx, pelvis, everything looks fine. There is no problem. But something wrong on the left side. Look at it. It is grossly dilated. There is an obstruction. Guys, all of them are AP views now. The PA view business was only confined to X-ray chest. Otherwise, all of them are anterior posterior. All other X-ray in the body are anterior posterior and lateral. So now look at it. This is called hydronephrosis, because nephros has been dilated. Hydroureter, and you can see this is a very classical appearance. This ureter is actually, there is a problem. I'll be showing you in upcoming picture. Doctor, the picture in the middle is AP. All the pictures are AP, gentlemen. Osama, all the pictures are AP. No one is PA. So look at it. There is a severe obstruction. This is a retrocaval. This ureter is going behind the inferior vena cava. This is a very unusual thing. This is an anomaly. So there is no stone here. But because this ureter is going behind the inferior vena cava, and that's the situation. Now surgically you can correct it. So you have to cut it from here, and then you have to realign with this. So you see that. So now this kidney, if it stays like that, this is a healthy side, this is a disease side. If it stays like that, the nephron starts dying, cortex start thinning out, and kidney is done. Finish. The kidney will finish its job, and we will be living only with one kidney. So this is a hydronephrosis, hydroureter. So water in the ureter, water in the nephros system. So this is, if you leave this thing as it is, it will be a disaster, and you will lose the right kidney, and person can survive only on the left kidney. So I'm sure you people have understood, and I have written down very small points. This is also an intravenous urogram, IVU, showing a classic retrocaval ureter. A degree of obstruction has resulted in markedly dilated upper urinary tract. How come the right kidney is higher than the, guys, these are depending on the position of the patient. This is not a classic patient is lying not properly, little bit up, little bit bended, little bit, because these people are in pain. They are not normal walking people. Who allows you to get an X-ray? Can a person live with 1/7 of the, guys, people, we'll talk about it. There are so many possibilities. There are so many things. People can survive with very little quantity of nephrons. But once it goes further, we need to go for a transplant. And guys, these are my favorite topics. I love to talk for hours and hours, but we have to respect the time. Otherwise, we'll not be able to finish it. But I love to stay connected with you guys, and I love to answer you. We'll set something. I will find some solution where I can be answering your question. This is a really important subject. And guys, this is my main field. I spend my life in doing these things. I really enjoy that. This is one of my passion. Now, what I'm showing you some diagrammatic images where I have shown you with the X-rays before. So you can see that sometime the ureter can be bifurcated. We call it duplex. Look at it. Different, a ureter, a duplex ureter, but it is not opening in the bladder. It is opening in the urethra. Look at it. There is an obstruction. So this is a dilated ureter. This is a normal kidney, and hydronephrosis, hydroureter. And look at it. This was the one which we were looking behind, the retrocaval thing. So see that the ureter is going behind the inferior vena cava. So this was the situation. Let me take you back to that slide. No, I have gone further. Why I'm not going backwards? Yes. Look at here. This was the retrocaval. And then this image, I missed that image at that time. So you can see that these are also the reconstruction. This is an MR showing you the same minor. These are the normal studies. There is no, how does the ureter go behind? These are the developmental. Paul will tell you. Ask Paul how we have retrocaval, ureters. Now, this is not because of trauma. This is because of developmental issues. So we are good with these things. So you'll spend time and you'll learn things better. Okay, let's proceed. So now I have brought some X-rays for you, and I want your opinion. What do you see in this X-ray? These X-rays are called KUB. Why we call them, these X-ray abdomen, we call them KUB. All of them are anterior posterior views, AP views. So you're looking at the kidney, you're looking at the ureter, and you're looking at the bladder. So what do you see in this X-ray? Can you write quickly in the chat? What do you see in this X-ray? Nothing. I love this. I love this. Okay, so I'll show you now what you see in this X-ray. Air in the ureter. There is no air. If air goes in the ureter, that's a disaster. Look at it. Can you zoom in here? Look at this place, and I have zoomed out for you. Look at it. There was a stone in the ureter. Are we good? So this is a simple X-ray KUB. No contrast is injected. So this we call it X-ray KUB. So you should have eyes. When I have eyes, when my brain knows. When my brain knows, I can implement everything. Now let's go further. The journey has not started here. Now what do you see in this X-ray? Write in the chat. The black is air. Excellent. Can you see something here, guys? Let me help you. Left hydronephrosis. No. Look at the right side. Excellent. Mashallah. You guys are now coming on the point. Excellent. I love you guys. So let me highlight it for you. Let's make your life easy. Now compare the two images. This is the normal side. Look at the abnormal side. There's a stone, and because of this obstruction, look how much, because this stone stays there for a longer period. And if this person will not get a surgical treatment, this kidney will be gone. Look at dilated ureter. Now you can compare. You can see now on both the sides. Look at hydronephrosis. Everything is gone. Can you anticipate? This is important, and we should be trained for that. I'll be giving you more session on this, so you'll be more good with that. Are we good? What causes the air to be there? This is not actually, this is your intestine. Your intestine, when you eat and drink and talk, some air goes in there. So this is that. And this is not actually the air much. This is the food content, some of the gases, the nitrogenous things. I don't want to go into the detail. What are the black spaces in the bladder? I'll be coming to the bladder, don't worry. Because these are my loops of intestine, small intestine. This is the area for large intestine. So you should anticipate this is a human with all the organs, not only with the kidney and ureter. Are we good? So now does the kidney becomes large a little bit? Yeah, it enlarges before dying, and then when it, now look at it in this X-ray. What do you see here, guys? Focus in the bladder. A chicken egg. What is happening here? Bladder stone. Excellent. Mashallah, you guys are now smart. So you can see that. These are the bladder stone, and this is phlebolith. We'll talk about it later, not today. Are we good? Okay, let's proceed. So now this is, I'm showing another example of bifid ureters, duplex. Why it's so big? I have taken out a stone of this size, like a honey melon. I remember. Never forget that. Now,